Yeah, very good morning. Yeah, it gives me immense pleasure to share our work. Uh, this acronym is called a Selective Endothelialectomy in a Peters anomaly, which was originally concepted, innovated, and pioneered at LV Prasad Institute for the last 10 years. Myself, MURALEEDHARA, I focus on a pediatric cornea. My co-authors are Divya and Sunita. None of the authors have any proprietary interest particular to this particular talk. As we all know, Peters anomalies are one of the most common anterior segment developmental abnormality, which present as a central or a paracentral corneal opacification, accounts for nearly 50% of children born with a congenital corneal opacity. Bilaterality is seen in about two-thirds of the cases, and it is also incidentally one of the commonest indication for a penetrating keratoplasty, both at LV Prasad data about last 30 years, as well as a EBA, which accounts nearly 65% of all penetrating keratoplasties being performed for a Peters anomaly in children. So this picture clearly depicts you have a central island of opacity. The OCT depicts there is a defect in the posterior lamella. And as I said, bilaterality is a two-thirds, and unilateral diseases are recalcitrant, moving to the significant amblyopia. It's similar to the unilateral cataract. And there are opacities which encompasses entire cornea, where UVM actually helps us deciding whether it is a type 1 or a type 2. Where a lens, you could see the anterior lens capsule. It is a typical type 1. And this is a type 2 where you have a keratolenticulo iridodyskinesis. It's a lens is failed to separate here. That's what OCT actually showing. If you look at historically last 4 decades, there are a variety of options in order to take care of the Peters anomaly. Primarily, keratoplasty is reserved for a very severe cases. Considering the longevity of these children, often end up with one of the complications, may have an abysmal prognosis, considering the life expectancy of each of these child. I went through the 4 decades of all the published literature, and only about 20 to 60% of them select cases can have a 2400 and above with less than 4 years follow-up. We published in 2020 the last case, the last column showing the row, 30 case have a 97% success rate and having 2800 or better. Mind you, these are all small children, they are pre-verbal, and you have challenges in documenting their visual acuity. So one of the premise for this entire project is that what we found, biologically, there is an anomalous Descemet's endothelial complex. This is basically a transcription abnormality. These abnormal cells inhibits the regenerative ability of the peripheral healthy endothelium. Therefore, these defects do not naturally heal. So by removing this inhibition, contact inhibition by virtue of the surgical removal, we are facilitating the normal endothelium to expand and results in a resolution of the scar and the opacification. This OCT you could see, this is an anomalous layer, and histopath also will show about anomalous layer, although they have a nascent or immature Descemet's membrane. So all we are doing surgically removing that anomalous layer. Also documented post-operatively, you could see the 1 week post-op, there is a corneal edema, and at this is the 30th 1 month. So you could see a fine reflective membrane, perhaps suggestive of a Descemet's membrane, although it doesn't show about endothelium, it's a surrogate marker. So with this background, we wanted to test this hypothesis prospectively. It was started October 2019 onwards. It's ongoing prospective study. And I've included here only those children who have at least crossed 6 months of follow-up. This is a surgical technique. It's a very simple, easy technique. First step is severing the communication between the corneal opacity and the iris colority, staining, establishing the defect size, and exactly analogous to the way we polish the undersurface of the anterior lens capsule, removing these abnormal cells and ensuring there is no DM detachment at the end. So that's it. Your surgery spontaneously heals. Cases which have a lens involved, where also remove the lens. And if the defect is much more than 7 millimeter, we add a sphincterectomy or a iridotomy. So the 6 cases where have a less than 7 millimeter had exclusively SEPA, and 25 eyes had a form of iridectomy, and only about 6 eyes where we have to remove the lens. And this is a sequential image of right and left eye. You could see this child has a little over 3 years follow-up, and you have a significant healing. And this is a partial resolution. This is a complete resolution. So for the variety of condition, we had a good outcome. And there is a significant improvement in the vision. Vision tend to continue to improve over the period of time. The risk factor for the partial recovery is the age and the severity of the disease. By 10 years of our work, both retrospective and extended study, we have actually shown there is a good outcome by doing a SIPA. This is our simple algorithm based on the mild, moderate, and the severe diseases. These are my references. Thank you.
We continue with Dr. Muralidhara for the next presentation.
Yeah, so Dr. Muralidhar, fantastic results that you have. So what was the age group, I just missed that, that you have done in these cases?
Yeah, it starts from as early as 6 weeks, and most of them are around 6 months age group. That's what the mean age.
You could get fantastic pictures in these children. How did you kind of manage to do the UBM and all that?
Yeah, because I had a good mentors who taught me, right from all investigations, including UBM, OCT. I do myself.
Okay. Do you give them anesthesia at that time, or? Okay. So what kind of anesthesia then?
We use sevoflurane.
I see. Okay.
Only inhalation. Yeah.
Did you need, other than the CPA, did you ever need in any child, did you need a PK or did you need something else that you needed to do?
No, madam. Our criteria were very, very strict. And of course, you have to have a lengthy discussion with the parents, considering the life expectancy and many things. So we excluded those cases which have a more than, zone 3, more than 7 millimeter.
Okay.
And you don't have even a small island of peripheral cornea remaining. So we went ahead with the keratoplasty.
Okay. And any comorbidities in these children? Did you ever have?
Excellent question. Yeah, the variety, right from optic disc, issues to, macular hyperplasia, and at least nearly 2/3 of them have systemic issues, right?
Like?
From cognitive impairment, cardiac issues, polycystic kidney, variety of systemic abnormalities.
So was it challenging to give anesthesia to such children?
Yes, particularly Peter Plus, you have that typical facial, configuration, everything. They have a hypoplasia, macrognathia. Yeah, it is a very challenging from anesthesia point of view also.
And what was the frequency of follow-ups? Like how frequently were you following them
This has
up?
become simplified. Once we have a surgery, my next anesthesia would be typically 4 to 6 weeks. That is the time I remove the 2 side port sutures. That is the time I also document all the OCT, UBM, and also measurements, the corneal measurements, resolution, and so on, including the retinoscope.
In the same sitting, you would do everything. So was it done in the OPD, your UBM and this and that?
So what I do, my OPD facility has a minor OR. So let's say I have typically about 90 is my pediatric OPD. Around 20 would be taken under anesthesia.
Okay.
So those cases which need a suture removal, need to revise any refraction, spectacles, or I have to check the intraocular pressure. If the eye care consistently shows eye pressure, so then I go and cross-check with the Perkins.
So did you need any AGM, glaucoma procedures, anything in any of them?
We have excluded all that had at outset. That's what, our outcome is 100% here. 100% of the cases had at least partial recovery. Nearly 60% had a complete full recovery. You could see that images. Full recovery means, we are able to see through the, the defect, able to refract, able to see the fundus, retina, everything. That's a surrogate measure, of course. And children also showed their visual fixation pattern, and the vision was continuing to improve because the child's, cognitive things are improving. They tend to do better. And most of them, 95% of them were all a pre-verbal age group, less
Okay.
than 3 years.
So none of them you needed to implant an IOL or anything. You just
No.
did lens-as.
Correct.
That's,
I think, apart from, since it's a neurocrystopathy, they also have a trabecular dysgenesis and they have a microcornea. I don't think we should really embark on doing the intraocular lens in these cases, at least. Considering their lifetime, particularly type 2, have a 70% of lifetime secondary developmental glaucoma. Therefore, it should be avoided.
so it's kind of a multi-speciality thing. You need the glaucoma person and everyone to chip in there.
Including the pediatric person, in case if there is any squint need to be corrected.
A lot of cases, I would say, in this period.
How do you decide how much of endothelium to remove? In all the cases, was the same value?
No, great question. So one of the first step, I severed the communication and injected the triphan blue. It's sort of, it'll help you mark. And wherever polarity, from the polarity, this iris insert that define the perimeter of the corneal opacity. Okay.
So the reason why I'm asking is because you have taken zone 2 as well, and you also told the rationale is for the side endothelial cells to come in. So if you're doing the zone 2, obviously you're not going to take it.
Great question. That's what, particularly microcornea, if you don't have enough residual endothelium around, so they don't do well. So yeah, we should not take such a cases. Absolutely. You need to have at least 1/4 of healthy peripheral cornea. And we all know peripheral endothelial reserve is much more than the central. And we also believe up to 2 years, they may retain some amount of mitotic potential. So unlike, DSO, so this is a much more biologically, much better procedure.
And did you use any rock inhibitor?
No. So the reason is, these peripheral cells are healthy cells. Unlike in a FP1273, so they have a mutation there. Those cells, do not, proliferate or expand. So that's what you need something, facilitate.